There's this microbe that's a true master of disguise. It hangs out in the soil, totally harmless for most of its life, but just one breath of it, well, that can turn into a full-blown systemic siege. We're talking about Nocardia. So let's dive into the clinical challenges this really fascinating and honestly pretty complex pathogen throws at us. Okay, so here's our game plan for this explainer. We're going to start with the basics, what this thing is. Then we'll get into the real detective work of diagnostics. After that, we'll talk treatment, how to contain it, and what happens when things get serious. And we'll wrap it all up with a few clinical challenges to really test our understanding.
All right, first things first. We've got to understand our adversary. Where does it come from, and how does it get inside the body?
So what exactly is nocardiosis? At its core, it's a classic opportunistic infection. The bacteria responsible, Nocardia, aren't out there looking for a fight. They're what we call telluric saprophytes, which is just a fancy way of saying they live in the soil and decompose things. But here's the catch. In someone with a weakened immune system, this harmless soil dweller can transform into a really serious threat. So how does it get in? Well, there are two main ways. You can breathe it in, think airborne particles from disturbed soil, or it can get directly into a cut or a puncture wound. It usually starts in the lungs, causing things like pneumonia or abscesses. But the real danger, the thing that makes Nocardia so scary, is its ability to spread through the bloodstream. And it has a knack for setting up shop in some really bad places, like the brain, the skin, the eyes, you name it. Okay, now for the diagnostic detective work. And trust me, this is where it gets tricky because nocardiosis is a great mimic. It can look like a lot of other diseases. So let's follow the clues from the clinic to the lab and see how we actually unmask this thing. The path to an ID is a pretty meticulous 4-step process. First, you gotta get the right sample. If you suspect a lung infection, you're gonna want some purulent sputum. Then, it's off to the microscope. Special stains can give us our first big clue. Step 3 is culture. And this is where you need patience. Nocardia is a slow grower. It can take up to 2 weeks. And finally, for the definitive answer, we turn to the heavy hitters, MALDI-TOF or 16S RNA gene sequencing to nail the exact species. Okay, this is one of my favorite parts because it highlights a really clever bit of microbiology. The key is in the stain. Nocardia is what we call partially acid-fast. Now, if you use the standard heavy-duty Zeal-Nielsen stain for TB, you'll probably miss it completely. It just washes right out. But if you use the modified Quinone stain, which uses a much gentler decolorizer, bam, it shows up. It's such a perfect example of how a tiny tweak in technique can make all the difference. And get this, sometimes the clues aren't high-tech at all. They're right under your nose, literally. Lab scientists who culture Nocardia often notice a very distinct smell coming from the plate. They describe it as earthy or like freshly mown grass. How cool is that? It's a throwback to old-school microbiology where your senses are part of your diagnostic toolkit. All right, we've got our ID. Now, the next challenge, how do we treat it? This is definitely not a one-size-fits-all situation. Okay, let's be crystal clear here. You can't just guess with treatment. The reason is that different Nocardia species have wildly different resistance patterns. One species might be susceptible to a common antibiotic, but another, like Nocardia farcinica, can be resistant to almost everything. That's why antimicrobial susceptibility testing, AST, is absolutely non-negotiable. You have to know what you're up against. And get ready for the long haul. Treatment often takes 6 months, sometimes even a full year, especially if it's spread to the brain. Now, just to illustrate how complex these treatments can get, look at this example for a different condition, endocarditis. You see these multi-drug cocktails and long durations? The key takeaway here isn't the specific drugs, again, these are not for nocardiosis, but the principle. For severe nocardiosis, you're looking at a similar level of complexity. We're often talking about combination therapy, maybe trimethoprim sulfamethoxazole plus something potent like amikacin or a carbapenem, all guided by that crucial AST. So what about the bigger picture? Let's talk about containment, control, and prevention. This is interesting because Nocardia isn't something you catch from another person. It comes from the environment. So there aren't really any specific public health reporting hotlines for it. In a hospital, it's all about standard precautions. The real key is prevention, and that's all about common sense, especially for high-risk immunocompromised folks. Simple things like wearing gloves when you're gardening can make a huge difference in avoiding exposure. Okay, now we need to talk about what happens when things go wrong. When the infection spreads or isn't caught in time, the consequences can be incredibly serious. This chart really spells it out. The lungs are the main starting point, yeah? But look where it ends up. The central nervous system, that's brain abscesses and meningitis, accounts for a full quarter of the complications. That is terrifying. Then you have eye infections and another 20% where it's just spread everywhere systemically. This visual really drives home how dangerous dissemination is. Now this is one of those clinical pearls you absolutely have to remember. It's so tempting to use corticosteroids to knock down inflammation in an eye infection, right? It's a common reflex. But with nocardia keratitis, that is the worst thing you can do. The evidence shows it actually makes outcomes worse. We're talking bigger scars and permanent vision loss. It's a powerful reminder that what works for one bug can be a disaster for another. Okay, time to put it all together. We're going to run through a few quick case challenges to see how this all applies in the real world. All right, case number 1. You have an immunocompromised patient and you suspect Nocardia pneumonia. What's going to be your go-to specimen to confirm it? The answer is B, sputum. And the reason is simple. You want a sample from the actual site of the infection. For pneumonia, that's the lower respiratory tract. Nasal or throat swabs just aren't going to cut it. They only sample the upper airways. You need that deep, purulent material. Okay, next question. Let's go back to the lab. What's the big deal about using the modified quinone stain for nocardia? Why is it so useful? It all comes down to that partial acid fastness we talked about. The modified quinone stain uses a weaker decolorizer, which is just right for nocardia. It's strong enough to wash the stain off other things, but gentle enough to leave it on the nocardia. It's a specific tool for a specific job, and it lets us see a key trait that stronger stains would completely miss. All right, final case. This one's about treatment, specifically for nocardia keratitis. Which of these is a big no-no, something you should absolutely not do? And the answer is C, local corticosteroids. As we saw, the evidence is overwhelming on this. Giving steroids in this situation can actually cause harm, leading to worse scarring and diminished vision. It's a critical piece of clinical knowledge that can literally save a patient's eyesight. So I'll leave you with this final thought to chew on. This bug is literally everywhere, in the dirt beneath our feet. It's a master of disguise, it's hard to diagnose, and it can be absolutely devastating to vulnerable people. So it makes you wonder, is nocardiosis the most underestimated opportunistic pathogen out there? In a world full of microbes, maybe, just maybe, the most dangerous one is the one you're not even looking for.